subject which we all sort of have to deal with, unfortunately, in our primary arthroplasty practice, which is periprosthetic joint infection. These are my conflicts, not necessarily relevant. I do some consulting for Heraeus Medical that makes antibiotic cement. So as you can see here, we have a panel of really amazing people, really experts who come from across the world, obviously here in India and beyond. And I'll be asking them for the next 40 minutes some very important questions. We want to learn what these experts do and what they do in their institutions. So the three sort of subjects are how to prevent infections, preoperative optimization, how to prevent infections, what they do in the operating room, and then finally how to diagnose infection. And we'll hopefully have less consensus. Less consensus means more discussion. Again, this is in the context of an uncomplicated primary knee replacement, so no sort of hidden tricks here. And really what I want to know from these experts are, do you do this, or what exactly do you do, and what does your institution do? And of course, I have one or two slides for the audience just to dig in terms of literature and what's necessary now. So let's talk about preoperative prevention. A little bit of this has an overlap from Dr. Berry's really amazing talk this morning, but I think it's good that we have new panelists and hopefully less agreement on what to do. So let's talk about body mass index. Because we've got a lot of topics to go through, we'll just have a simple raise of hands here. Does anybody in the panel have a strict body mass index cutoff? Raise your hands if you do. Go ahead, Ashok. What's your number? I think you said it this morning. Remind us.
40.
So that means that when they come into your institution, they come to your clinic, you put them on the scale, and you tell them, not for me, sorry, or you have to go lose weight. What do you tell these people?
I tell them that 40 could extend to 42, but not grossly over that. I tell them that that's my cutoff. If I was to perform surgery, the risk of complications is going to be higher. It'd be better for them to look at alternative measures to cut down on the weight, whatever they want to do. If they still insist, then I would go, but my cutoff is 40, 42.
But Ashok, what if it's all in the belly and the knee is normal?
Great question. Great question, Ed. So the question was, if the body habitus is actually quite large, but the knee itself looks quite slim, will you reconsider?
No, because the weight is still going through that same knee.
Okay, so you're worried about mechanical wear.
You believe in the mechanical. It's mechanical load.
It is a mechanical load, and the risk of loosening. I think there is enough evidence that heavy patients have a higher incidence of loosening.
So before we get into the entire mechanical complications, I want to steer us towards infection prevention. Thorsten, you also put your hand up. What's your cutoff?
Yeah, my cutoff is also 40. And independently how the knee looks, I mean, most of the patients are suffering from a metabolic syndrome, and this is weaken your the situation maximally.
Very good. So then, in the event, does anybody on the panel have specific specialists or individuals that you commonly refer your patients to? Do you have access to a weight loss clinic or internal medicine or endocrinologist? Anybody here have that specific pathway in their institution? Michael, go ahead. What are our infectious disease specialists from HSS? Dr. Henry.
We do have a program set up at HSS to assess people preoperatively for obesity. Unfortunately, it is very, very oversubscribed, so only a small fraction of patients actually manage to get through the program. And it's made up of dietitians, physiatry, and internal medicine.
Go ahead. I think someone else had their hand up. Any specialized referral centers?
We have a center we refer our patients who have a high BMI to.
Great.
But then the question always is that you have to balance it with the amount of discomfort the patient is having in their knees, and that's often a challenge. How far do you go with these patients? But yeah, we do take a call, taking our colleagues in.
Yeah, so I do have a question about bariatric surgery. We actually answered it this morning, and I think there was a lot of enthusiasm in North America, especially to refer patients to bariatric surgeons probably about 10, 15 years ago. That seems to have decreased just because of the concern of weight gain and then, of course, disturbance in the actual metabolic pathway. What about GLP-1 agonists or Ozempic? In the United States, we've really seen an explosion of this medication. For our panelists from India, have you seen this as well in your patient population? Is this accessible to you?
We have no experience with that.
Okay, so I think the main experience from HSS, where we've had a lot of patients use it, is that it does work. It's actually been quite tremendous in seeing how patients have lost weight. The only main concerns, at least from a perioperative point of view, is that it does cause some gastric paralysis. So usually we actually counsel patients to be NPO even earlier. And then sometimes we'll even do an ultrasound of their stomach to make sure they don't have food in the stomach. It can be a bit of a nasty surprise. We touched briefly on albumin. I know we talked about vitamin D in the previous session. I think some panelists from this morning do get preoperative albumin. Who on the panel here gets routinely a preoperative albumin on all of their patients? We have 2 hands, 3 hands going up, 4 hands going up. Okay, guys, so I always hear this at the talks. I get the albumin. If it's low, I then go ahead and give them a supplementation. For the people who have their hands up, I think, Ashok, you're here first. What do you tell patients to do? Go see a nutritionist? Do you give them a specific supplement? What do you do?
It depends on what the level of the albumin is. If it is just borderline low, we go ahead with it. But if it's really low, I think there is enough evidence even from the MSIS criteria that these are patients who are at risk of problems and infections. So we will actually supplement that albumin. At times we'd send them back home, put them onto our medical colleagues, get it up to speed, and then go ahead with the surgery.
Perfect. I think that's a pretty reasonable thing. Anybody have anything else to add with that? Yes, I think the main cutoff just to go ahead.
Protein supplements, prescribe them, and then wait for it to come back to normal.
Yeah, I think the only difference with vitamin D is that albumin does take quite a while to come back up. So I think that's the main challenge that we have in terms of when to know when to correct it. And then just one more thing. For your obese patients, for those who do end up taking those patients above BMI 40 to the operating room and to do a primary knee, how does it change in terms of your wound management? Does anybody change their method of closure for a body mass index over 40, over 45? Anybody change strategies from what you usually do? Use of wound vacs, use of drains? Go ahead.
Stratafix in such patients when I'm doing the closure, but other than that, nothing beyond Stratafix for my closure.
Anybody have any experience with negative pressure dressings in these patients? No? You will see in our institution, some people do like to use wound vacs on these patients because of the concern of increased drainage. How about implants? Stemmed components, briefly, yes or no? Will people attempt to put a longer stem on the tibia in obese patients? Anyone raise their hands?
Stem extension in all the patients.
Okay, so we do have some people who like to do that. Just for the sake of time, of course, if you look at the literature, it seems like a BMI over 45 reproducibly has been found to be the inflection point for a really significant increase in risk. I think all the panelists are completely correct. And then, of course, as you can see from these multiple publications, patients cannot lose weight by themselves, but even with our help.
Can I make
Go
a
ahead.
point? There was a recent article, I think, in the February edition of JOA, which actually alludes to the fact that patients with stems in the 35 to 40 actually have a higher incidence of loosening, which really didn't sort of sit comfortably with me. I just wonder if the panel has a view on that. Over 40, they say yes. 35 to 40, they say it has a higher incidence of aseptic loosening. It's in the recent edition of JOA.
Anybody else familiar with those findings from the articles? Want to comment on that? So I can tell you personally, I guess it depends on the type of implant that you utilize. I tend to utilize an implant that actually has intrinsically a very short keel and stem, so I find myself putting a stem extension on everybody. But I think your point is well taken. A lot of these has to do with where exactly the obesity lies, perhaps bone density as well, and then method of fixation. So I think these are all comments. Aaron, you want to make a point?
I think it also depends on what alignment that patient has been put in, because if you're going to keep a very obese patient in significant malalignment or in severe varus, for example, your stem may not be adequate for the purpose.
Good points, all good points. Go ahead, Thorsten.
To be honest, there are some randomized studies which show that the stem extension has no benefit at all. So, I mean, the most crucial point is the bone quality. I agree, bone quality is quite weak in many obese patients, but if the bone quality is quite good, you don't need stem extensions.
Fair enough. Just for the sake of time, I do have some comments about smokers, diabetics. We covered a lot of that this morning. I don't think there's really anything else to add apart from your own institutional variants, dental health as well. I think Dr. Berry's talk covered that very nicely. How about intra-articular injections? The patients come to you in clinic, they've just had a cortisone shot, they just went to see another practitioner, gave them a shot or gave them a visco supplementation shot. They now want a total knee because it didn't help them. It's been a week later, they're still in as much pain. Anybody here, who here on the panel will do a knee replacement right away? Who here will delay? People who will do the knee replacement right away, it doesn't matter about the injection, it doesn't affect me. Add your hands up there. What's your evidence?
Pearl diver, 13,000 patients, 2 weeks. Anything after that makes no difference. Within 2 weeks you stop, but anything after that is good. Pearl diver.
Anybody else? 3 months. We got 3 months. Who else does 3 months?
3 months.
3 months. 3 months. Okay, fair enough. So we said we don't have a complete consensus, and actually it's quite interesting. The literature would tend to support this lack of consensus, because here I've got two things on the left, clear increase in PJI, and I do have the Pearl Diver study, at least a reference to it that Ed was talking about. So there's not complete consensus in the literature, but still at HSS, I'll tell you the majority of people will probably wait 3 months. Also has to do with the logistics of scheduling, but at the same time, I think we could definitely continue to ask this question. In terms of MRSA, we talked a little bit about this morning about how to deal with this. What exactly are your institutional guidelines for dealing with MRSA? Who here in their institution decolonizes everybody for MRSA? All primary knee patients. Anybody put their hands up? Anybody who has a history of MRSA? The patient comes in, I had a previous MRSA infection, you'll go ahead and decolonize. Okay, it seems to be the majority. Anybody else? The last two, what do you guys do in your institution?
All our patients are screened for MRSA before surgery.
So you screen everybody?
We screen everyone, yeah.
Okay, perfect. Ed, how about you?
Ironic, we screen on admission and don't treat. So I don't treat any of my MRSA. And you gotta ask yourself, if you're colonized with MRSA, how did you get it? What does it make? What does it make a difference to get an infection if you have something in your nose? It's your gut causing your change. It's your diet. It's everything that Thorsten has talked about. Changing your gut, changing your diet makes the difference. Getting rid of it out of your nose is not going to change your infection risk. It's everything else in your body.
So Mike Henry, you're our infectious disease specialist. What do you think the literature shows about this? What should we be doing in terms of what the literature tells us? If you could steer the reins at HSS and tell us all what to do, what should we be doing which makes the most sense in the literature?
Well, one thing I just want to point out is that it's not just MRSA, but it's MSS. It's all Staph aureus, which puts people at increased risk for post-operative orthopedic infections. And we screen people only with a reported history of Staph aureus infection or colonization, which is albeit a very imperfect way, and we'll be moving towards sort of universal decolonization with no screening. And in terms of, it's an interesting question. What is it? Why clearing out the nose? Why does that help? People will, most of the staph does live in our nose, warm, dark places. With staph there, it's very easy for patients to then auto-inoculate themselves all over the place, which is why you like to reduce the staph load. So it's not simply just the staph that's traveling through the blood from the nose or through the air through the nose, but the patient actually can spread it to themselves.
Yes, that's great. Thanks so much, Mike, for giving us insight. It never really made much sense to me until you explained it to me. And Ed, I think at that point, if your institution right now screens but doesn't treat, you've got the perfect setup for a wonderful study. Now just screen and treat everybody, and then you can actually tell us what the answer is in a few years. Anyways, obviously there's a little bit of variation here. The next thing that's more interesting, if you do know your patient is an MRSA carrier, who here will modify their intraoperative antibiotic prophylaxis because of the MRSA status? Thorsten, your hands up. What do you do then? So first of all, what's your routine prophylaxis if a patient is not an MRSA carrier?
Our routine prophylaxis is cefazoline, as it mentioned before here. And if a patient has some kind of a history of MRSA infection, we give vancomycin 1 hour before.
Anybody else do the same? Mike? Dr. Malalji, why don't you tell us, are you doing the exact same thing? You're also telling us that you don't have access to the first generation cephalosporins.
Yeah, we use cefuroxime and Vanco.
And that's it. So that's what you add on. And then in terms of the two of you, do you then try to get that into the patient a few hours before surgery? Does that alter your scheduling? Do you not schedule them first in the day?
We'd already have treated them with mupirocin initially.
Okay, but you obviously want to make sure that vent goes in before obviously the tourniquet goes up. Okay, great. And this is obviously some good data. Definitely a lot of discordances you can see among the panel, but it seems like there is some good data, especially from NYU down the road from us, that universal decolonization seems to be quite cost effective. It is institution variant, and definitely as you can see here, there are some really compelling results that if you do treat it, the institutional rates, which can be high, actually do tend to come down. Let's switch to now intraoperative. I think this is kind of interesting because we did touch a little bit upon this morning, but I would dig into it a little bit deeper. So let's talk about types of anesthesia. On the panel, in your institution, general anesthesia is the main technique for my total knee replacements. Put your hands up if that's true. Okay, so we got one. How about spinal neuraxial anesthesia for everybody else? Would this be the overwhelming majority? What do you think your institutional percentage? Just going down the panel over the last year, the number of patients, percentage of patients who had general anesthesia in your institution.
2 to 3%.
2 to 3%. Please go ahead.
Very low.
Thorsten.
80 to 20%.
80% neuraxial.
Spinal, 80% spinal, 20%.
Very low. Only if the anesthetist feels that a spine surgery has been done or some contraindication for that. Otherwise, it's always spinal.
Okay. Anything else to add?
Less than 5% would be general anesthesia.
Okay, so Ed, let's have some. I have to single you out here. Let's talk a little bit about this. Is that because your anesthesiologists don't want to do it? Is there a push for the surgeons that prefer general anesthesia? Take us through this.
Or slow anesthesia general is fast. We're at a teaching institution. If you have a lot of residents and they got a couple pokes, it takes time. You lose time in the OR. It's efficiency. If I have a good anesthesiologist, great, but it's week by week. It's different.
Great. I mean, it's a great question to ask because obviously anesthesia technique has been shown to have helped not only recovery but also blood loss. So it's interesting to see what does some institutions. Just tourniquet real quickly. People, put your hands up if you use a tourniquet during your primary knee replacement. And on the panel, put your hands up if you use a tourniquet. Okay, so again, we do have not complete discordance. We talked about that this morning. Tranexamic acid. Who here does not utilize tranexamic acid routinely in their total knee arthroplasty? Okay, number of doses. Who gives just one dose in the majority of patients? 2 doses. Okay, so again, not complete discordance here. Who gives it to pretty much everyone, as we heard from Dr. Berry? There's some good evidence to show that most people can take it. Would you say over 90% of your patients get tranexamic acid? Put your hands up if that's correct. Great, so see, at least we do know that there are different, at least at HSS, my anesthesiologist tends to get nervous if there are stents, recent cardiac issues, but on the fence sometimes, but that's really probably more institutional specific. In terms of donating blood, do any institutions from the panel, do your patients routinely give blood before surgery? So just to make sure, that seems to have been completely abandoned in North America, just wanted to make sure that was the case across the world. And then how about a transfusion protocol post-operatively? In terms of how you find your rate of transfusion now versus previously, obviously we know tranexamic acid is a game changer. Do you actually have codified protocols in your institution to try and decrease the use of actual blood donation? Yes, so Thorsten, you're nodding your head. Give us some explanation there.
Yeah, of course, we have a quite strict protocol. It's depending on the clinical symptoms, on the clinical situation. So if a patient has less than 7 and shows some kind of clinical symptoms, we give some blood. Mm-hmm. If not, we wait.
And then if they have a cardiac history, obviously the numbers are different a little bit?
There's no difference, no.
Okay. Anybody else have anything that's vastly different? Please,
7 in cardiac.
7 in cardiac. Arun, is that the
Anyone
same?
with symptoms of dizziness, giddiness, etc., and a cardiac history, we'd be more careful and give them blood. But otherwise, our cutoff is around 8.
Fair enough.
Less than 8, we transfuse.
Does anybody not have a protocol? No plan whatsoever? So I think that's the important thing. If you don't have one at your institution, please develop one, especially with your internists, to make sure that you're all on the same page. In terms of the environment, at HSS we have our hallowed panels, our plexiglass panels that we know and love to make sure the laminar flow works properly. Who here on the panel utilizes laminar flow routinely in their primary total knee arthroplasty? Okay, so it seems like the majority of people do. Ed, you didn't put your hand up. Tell us a little bit about your setup. Do you have any? How do you maintain sort of a different position as to not having outsiders come into your surgical field? Are you quite militant about that? Is it
standard flow? Everybody comes in through the core, not on the outside. The doors are taped shut, and exhaust hoods only, and that's it. And minimal traffic flow. And we just don't have the rooms for laminar flow.
Fair enough. It would be interesting to sort of know what the actual setup is across countries. We definitely have conflicting evidence in the different international registries. At HSS, we've been having some rooms on the other floors which don't have laminar flow, and we're doing some joints now. We've installed laminar flow, but the matter of fact is that it still seems to be the preference among a lot of institutions.
But if you go to outpatient ambulatory care centers, they do just as well, and they have no laminar flow, they have no core, they have no nothing, and they do just as well.
Yeah, we're going to talk about outpatients in a second, but you're absolutely right, Ed. I think now the switch to ASCs in North America has been a huge game changer. It'll be quite interesting to try and figure out how many of them have the same environmental setup as a hospital. How about skin prep? Let's go down. Let's go down. Starting with Ashok here. What type of skin prep do you use for your?
We use chlorhexidine preps. We have chlorhexidine washes, baths, and we prep with chlorhexidine as well. So we.
Chlorhexidine, betadine, and alcohol.
And is it in that order specifically?
Yeah.
Okay. Thorsten?
Betadine and alcohol.
Same like Dr. Arun Mullaji, and no shaving, only trimmers to be used.
Okay. Please continue, everybody else.
Betadine scrub followed by chlorhexidine alcohol prep.
Ed?
Alcohol, then Duraprep and Ioban.
Alberto, why don't you say what we do at HSS?
So at HSS, what you typically do, or at least historically, there was a little bit of a divide. We actually were a bit chlorhexidine and a bit povidone iodine. Now the service has really switched more over to a complete chlorhexidine utilization. A little bit of povidone iodine on the foot, which will then hold up, and then a chlorhexidine. First a pre-scrub, and then a proper 3% prep with chlorhexidine, which you then wait. I think the main thing is that an alcohol-based prep has really been shown to be superior over and over again. Povidone iodine is quite effective, but I think chlorhexidine has been seen to be superior and very reliable. In terms of these adhesive incised drapes, you can see I've made a picture up there to show these are these iodine impregnated incised drapes. Just for the panel, please put your hands up if you utilize these in your operating room for your primary total knee replacements. Okay, so it seems like we actually have did we actually have universal consensus there for once? Seems like we may have. Everyone seems to use it. In terms of the literature, is anyone convinced that this makes a compelling difference from what you know about the literature? Put your hands up if you think it makes a compelling difference. Okay, let's talk a little bit about that. Okay, so Dr. Mullaji, talk to me a little bit about why you think it makes a difference. Where's your data coming from for that opinion?
I think there was a study from Germany actually which measured the area of the skin that was exposed and correlated it with the infection post-op. So if you had skin uncovered with the drape, you had a higher rate of infection. That's the only study that I came across.
Yeah, and this was really a weak study, to be honest, and we had this question during the consensus meeting, the ICM, and where the answer was quite clear based on the whole literature. There's no need for incise drapings, except probably the ioanized, the povidone was.
Right, Ed, go ahead. You put your hand up.
Back to Maurice Mueller, though, but Maurice had thousands and thousands of hibs, and he always claimed it was his covering that kept his infection rate low. Yes? Yeah?
Well, I think we can certainly agree that apart from some registry-based studies, especially one that actually showed that not having the iodine was dangerous, I don't really think we have very well-controlled or well-designed studies to answer that. But we'll keep on using it anyways because it does make us feel better. Anyways, in terms of just small things, changing your blade from the skin to the arthrotomy. Does anyone here not change the blade? Uses the same blade to go through the skin and then through the arthrotomy. Anybody? Okay, so one person who does that, that's important to understand. How about changing your gloves? How often do you change your gloves? Let's just go, Ed, starting with Ed. Do you change your gloves? How often? Do you have a time limit?
1 hour.
1 hour, so the timer goes off, everyone change their gloves?
As well as the suction.
And the suction. Just keep on going, let's go down the panel. Anybody else?
Before cementing.
Before cementing.
Yeah, change before cementing.
Me too.
So when that happens and when the cement sticks to your glove, what's the rationale for doing that?
You should change it after cementing because the cement is destroying the glass.
Okay.
And, that's a problem. But I change them before touching the implant. That's my.
And so for the people who change it when you cement, so you change it before you cement, then you change it after because all the cement's on the gloves?
I should change it after cement. I don't do it.
Okay, let's keep going, please.
I change it just before I open the implant and cement it in, and then I don't have the problem of having to remove it because I'm washing out after that.
Fair enough. Ashok, please.
I don't change my cement. I don't change the glove.
Fair enough. So I actually go ahead and cement, and then when I'm using my antiseptic solution, I change it right after that. We'll talk about that. Thank you for that. In terms of antiseptics and antibiotics, we'll talk about it. I think Dr. Berry summarized it very nicely. Antibiotics in the cement. All the time, high risk, or really never? Who here goes ahead and does it all the time in all patients? And how about just for high risk? And Ed, I see you didn't put your hand up. Go ahead.
Never.
Never. Rationale for that?
I believe that antibiotics create resistance, and I believe that less antibiotics are better. I do 1 dose of preoperative antibiotics and no antibiotics in the cement.
So the infectious disease physician has applauded you right there.
It is absolutely true because the more antibiotics we do, the more resistance we get.
Great, that's wonderful. I'm happy Dr. Henry is happy about that statement here. In terms of the people who do add antibiotics, are you using commercially available antibiotics, your aminoglycoside that's been pre-mixed? Or does anybody go ahead and add it manually and stir it in, whether it be for elution properties or cost?
We have to differentiate between primary implantations and revisions due to PJI.
Sure, so we're talking about primaries here.
Yeah, primary pre-mixed.
And then quickly, if you have a MRSA carrier, does anybody go ahead and add vancomycin whether it be pre-mixed or not. There are some antibiotic cements that now have dual.
Actually, I do.
So you do. Okay, I know that's specifically available in Europe. And then in terms of vancomycin powder, interesting literature from the spine now beginning to creep into the orthopedic practices of joint replacement surgeons. Does anybody here in a primary setting or an aseptic revision setting sprinkle in a little bit of the magic powder before they close the incision? Anyone do that?
I don't sprinkle it, but we keep irrigating with vancomycin solution throughout the surgery.
And is that something you do in all of your cases? You had some,
All cases.
any concerns about vancomycin resistance?
No.
No. Okay. So it's interesting how we have very different opinions in terms of antibiotic stewardship for that use. Okay.
So, Alberto, I'll just point out, in the spine literature, the development of resistance has not been a problem, for whatever it's worth.
Whatever it's worth. Good, at least as far as we know. Let's talk about something that I'm very passionate about, antiseptic solution. So interesting data now about 12 years ago from Rush showing that dilute povidone iodine decreases the risk of infection when you put it after you cement and put your implants in before you close. Who on the panel utilizes some form? So I think we do have Dr. Malalji utilizes his vancomycin. That is an intra-wound antiseptic or antibiotic. Does anybody else utilize an antiseptic or antibiotic solution prior to closure? Put up your hand if that's the case. Okay, tell us about what your formulations are. Go ahead.
We use 10% betadine.
10% betadine. Okay.
0.5% betadine.
0.5%. Now, is that something you have to actually dilute yourself on the back table with some saline? And then, Dr. Malalji, do you have to use anything else?
The same, diluted. And the real question is it sterile? So our lab actually tests it frequently to make sure that it is sterile, the betadine that we get commercially.
Great. So I think that's an excellent point. So you do bring up an importance as to that the CDC in the United States did detect in 2003 some concerns for antiseptic solutions that actually contain water-based organisms that were not removed at the time when the actual water was mixed with the antiseptic solution. That's why now in the United States they recommend that if they have an antiseptic solution, it says the word sterile on it. At least in the US, the main hack for many years was to utilize what was in the Foley packs because that was sterile povidone iodine. Just in terms of antibiotic cement, real quick, there's this really lovely paper which actually highlights what we call the transatlantic paradox, which describes how in Europe antibiotic cement does have pretty conclusive results that it is protective, but in North America we've never really been able to show such an effect, and I think perhaps this is why we have this maybe disparity in us using it. What's interesting is this really large NJR study from England which actually did show some effect, but still I think if you have a panel of surgeons in the United States, you will not get concordance. One thing that we've been doing at HSS is looking at these antiseptic solutions. So in my hands, 10% povidone iodine with or without peroxide has been shown in our lab to kill absolutely everything. I use it in all of my primaries, so I applaud the panel member who does the same thing as I do. But the matter of fact is that the literature does suggest you should think about doing this, especially in your high-risk patients, and of course, irrigating it out. This is some nice data showing that the 10% really works on all orthopedic surfaces. There are a lot of new solutions on the market that are very expensive. Whether they're really going to be helpful still has to be worked out. Our in vitro data wasn't so reassuring. In terms of wound closures, primary, uncomplicated, non-obese patients, who here uses staples? Who here uses sutures? So let's talk about staples. Anybody using staples? Primary, non-obese patient for total knee. Okay, we have one person. How about sutures? So absorbable stitches. Okay, does anybody use something else I didn't describe? Not really, okay.
So I use a combination of absorbable, subcuticular, and a few staples, just about 4 or 5, just to hold the wound together for early rehab.
For early rehab, so allow early bending in case you're worried about it splitting. Thorsten, talk to us about why you like to use staples.
It's quicker.
And then have you had any issues? So let's talk about the sutures.
No issues. There's no evidence that staples are more tending to infections than anything else. So we don't have any problems with staples.
And for the people who use sutures, who here is using an additional adhesive, some sort of glue that goes on top of the sutures? Anybody? So I'll tell you, in HSS, now the actual service standard that we've adopted is to utilize 3O monocryl as well as some Dermabond, which is a glue, and then a hydrocolloid dressing on top. So that's made a few people like me who love doing staples have to try and convert to a suture format. Just quickly about dressings. What do you do now with your dressings? You put a dressing on. Are you putting a gauze? Are you putting bandages and putting a dressing later? Or are you putting some sort of dressing and then you leave it and you ask the patient not to touch it? Who here actually leaves the dressing on and has the patient not touch it for a week or 10 days? Anybody? And so, Arun, let's just talk about what do you do for your primary needs in terms of your dressings?
So we actually just inspect the dressing before they go home once, but we don't leave the innermost gauze. We're not checking the wound as such, but we're just looking for any leakage because we wrap it up in a bandage and keep it for 4 or 5 days. So we just want to make sure that before the patient goes home, it's fine.
And then after 4 or 5 days, that bandage...
Nobody touches it.
And then after 4 or 5 days, that dressing comes down, bandage comes off, the wound is exposed?
Only the outer bandage comes out, and then we have this inner dressing like this.
Okay, fair enough. In our institution, we're really using these, what we call hydrocolloid or waterproof dressings, so the patients can shower. So we tend to put it on and then leave it on for about 10 days, 7 to 10 days, and then we pull it off. So it's interesting to see it. And then in terms of the dosing of IV antibiotics, so I'm not talking about your high-risk patient, I'm talking about routine total knee replacement. How many doses, if you're giving a dose before we cut the skin, that's 1 dose. And then of course there's a possibility for 2 doses, or maybe even 24 hours. So let's talk about this. In your primary knees, patients going home or staying overnight, who only gives a single dose of antibiotics routinely? And now what about 2 or 3 doses? Anybody giving additional post-operative doses? Okay, so then for the people who are doing additional post-operative doses, as we begin to move to outpatient joints, Ashok, let's talk about you. Now you have patients who want to go home pretty quickly, or you get them done late in the day, and they're going to be going home the next day at 8 o'clock, they're ready to go, their family members are ready to pick them up, but they're going to miss that 3rd dose or 2nd dose of antibiotics. Do you keep them in the hospital until they complete their 16 or 24-hour dosing? What do you do?
So we don't have that problem at all. Surgery for us is a social occasion. They like to stay for 4 or 5 days, so we don't have that challenge at all.
So then as we talk about antibiotic stewardship, do you think there's any concern about giving them more antibiotics when you don't need to?
Not necessarily. If you're doing it in a clean, safe environment, we administer 3 doses, 1 pre-op, 3 post-op, and that's it.
So Dr. Henry, you're an infectious disease specialist. You don't want us to give any antibiotics at all when not necessary. What do you think about this in terms of literature for 1 dose or more than 1 dose? What should we do?
Well, there is some recent evidence showing that just that single dose has actually always been shown to be by far the most important dose. And we do use a 3-dose, well, for using a Q8 drug like Ancef, we do give 3 doses. For the patients going home in the ambulatory setting, the surgeons have been sending people home with oral cephalosporins in its place. Mm-hmm. You know, that's sort of a jerry-rigged solution, and it's most likely we're riding on the coattails of that first single dose more than anything.
So just for the sake of time, because I want to touch on PJI, obviously, who here does give extended or 7-day oral antibiotics in high-risk patients? Okay, so for the sake of time, because we can get into this, we'll just say that there isn't complete consensus. There are 2 papers that came out from a specific group that did show significant reductions. The issue is that other institutions have not been able to show this. I want to touch on PJI diagnosis. We'll go through a little bit rapid fire. You can see the literature on this is exploding, and unfortunately, as you can see, even our 2018 criteria in 2018 have now been completely overwhelmed by the amount of evidence. Now we've got 50% of the literature was published after the 2018 criteria, so it's really quite interesting to see what the relevance of the criteria are. Obviously, everyone here is thinking about ESR and CRP. Does anyone here get something else, like IL-6, in terms of serum blood work? Anybody use any of these alternative markers from ESR and CRP? But okay, so go ahead, Ashok.
We use D-dimers and leukocyte esterase.
Anybody else using D-dimer routinely to work up their PJIs? Thorsten, go ahead.
No, we don't use D-dimer, but we use IL-6 only in one situation, if the patient is pre-septic.
Okay.
Just to see how much he's in danger at the moment.
Fair enough. Interesting. And then in terms of the aspiration, we have to go quickly because we're running out of time here. How long, when you're taking some fluid out of the knee, you're worried about infection, you're sending off cultures, who, in their institution, who here routinely keeps all cultures for 3 weeks? You can put your hands up as my dates go down. 2 weeks. 1 week. 5 days. 3 days. Well, what's the answer?
They don't culture.
Would it just be less than a week? What do you guys typically do? Go ahead.
We would normally keep it for 5 days, but then in cases where you haven't grown anything and there's a problem getting some data on what is going on inside, then we keep it for 14 days, but not as a routine.
Fair enough. So I mean, in our institution, we typically routinely keep it for 2 weeks just because of the concern of slow-growing organisms. There's some good literature there. In terms of surgery, you're worried about infection. You're taking samples. You're going to take tissue samples. We'll talk about the rest after. We'll talk about the number of samples that you would take when you're suspecting an infection. I'm going to start with a higher number and go down. 5 or more. 3 or more. And less than 3. Okay, so anybody have any strong opinions on this in terms of how many you should take? Ed, how many cultures should we be taking? Is 3 enough?
If it's infected, I take them everywhere, so you want to know, including medullary canal. If you just suspect infection in the knee, it's synovium is your best bang for your buck, then metaphyseal edges, patella, femur, tibia.
So do you get any pushback from your pathologists if you send them, or microbiologists send them 15 samples? Do they get a little bit upset?
Of course they do.
Okay. Good to know. So at least there are lots of good evidence here. You obviously have now with modern implants, if you do have early loosening, you should be worried about an infection. Metal on metal can certainly interfere with your counts. You think about specific differentiations. In our institution, we're now moving towards 5 cultures, as really just because we can remind the surgeons, and usually taking it with separate rongeurs or separate specimens. Swabs have not necessarily been helpful. And now, very appropriately, since we're running out of time, you do the aspiration. You haven't taken the patient to the OR. It's negative. There are all of these different technologies that are out there, ranging in their complexity and also their need for use of things like data informatics. If you're not in an academic institution, you may not have access to quantitative PCR. Let's just run down the panel. You have a culture negative infection. We'll start with Ashok here. What are you doing next? Are you simply re-aspirating the patient, or are you using any of these other technologies that I've listed here below? Go ahead.
This is a very difficult situation. We re-aspirate, oftentimes that comes out negative as well. We keep the cultures, like I said, for 2 weeks. Sometimes even at the end of that, you don't get a... So we rely more on the serology, the synovial CRP.
But then you're not doing any of these other techniques routinely?
No, we are not.
Not right. Just going down the line. Arun, what are you doing? Any of these techniques?
The first 3, generally. And now we've got some newer equipment for doing one of these more fancy tests, which gives you within an hour an analysis of about 20 odd organisms.
Has that been a game changer for you? Do you find that that's been really helpful?
Yeah, I think it's been really helpful.
BioFire joint panel, okay, that's one thing. And has that been a specific expense? Is that quite an expensive thing that your patients have indicated about, your institution's thought about?
Yeah, it is expensive, but I think it's in the earlier phase, so it's getting subsidized a bit.
Mike, what do we do here at HSS?
Well, we will re-aspirate, and on some occasions, we don't routinely send our synovial fluid cultures and blood culture bottles, but we can, when we request the lab there, they do it. We just don't have the infrastructure to do it for everybody. So we'll do those too. However, if the patient is clearly clinically has a PJI and the initial workup was culture negative, we'll often just proceed with the surgery, thinking we're going to get better cultures at the time of the OR. Even if you re-aspirate the second time, it's probably not MRSA, staph, Pseudomonas, any of the biggies. Those will grow out.
Great. So I want to ask about reimplantation. So Thorsten, quickly, I know we're talking about alpha defensin, but any of these technologies you use?
First, reaspiration. Second, open biopsy. We send only blood culture bottles if you have a longer transport time to the lab. Usually we use native material. Sondication you can only use if you have an implant, if you take the implant out. Molecular techniques we use, multiplex PCR, and sometimes next-gen sequencing.
Why not just use next-gen sequencing and everybody else? Why bother all this?
It's much more difficult to get it in Germany than in US. In US it's easy,
Perfect.
but
down the panel. Anybody else?
So
tell us the rest of
BioFire is available now for us, so we are using more of that.
Perfect. Go ahead.
So all our aspirates go in blood culture bottles in the first place. And if that doesn't work, then we use NGS.
Great. Ed, briefly. I know it's a huge topic of your passion.
Because BioFire only gets 75 organisms. Next generation gets 57,000 organisms.
And you treat for all the organisms that are positive. They come back with 23 organisms, and you get 4 antibiotics. So you're going to use all 4?
You pick a regimen that treats a broad spectrum.
Great, good answer. Just for the sake of time, this is really exciting. We could talk about this for a long time. Just quickly, because we can go a little bit over time. We're getting ready to reimplant. This is what the incision looks like. The patient feels good. That's a beautiful spacer you put in. We put some metal in there, but it's okay. How do you work up your aspiration? Who here in this regular patient with a primary need, you've now revised, they've completed their antibiotics, whether it be oral or intravenous. Who here will use an antibiotic holiday? Put your hands up. Okay, so Thorsten's the only one who does not. And then for those people who do use an antibiotic holiday, let's talk about duration, okay? So you can put your hands up, let's give you time. So 2 weeks, I'm gonna go up in time. 2 weeks, 6 weeks, 3 months, 6 months. Anybody else that didn't put their hands up? Okay. So Arun, for you it's 6 months?
6 months to a year, yeah,
And that's all comers regardless of the pathogen?
almost all.
Okay, and Ashok, just over here to say, because you put up your hand for 6 weeks, what about fungal infection? You do anything different? You go longer?
If it's fungal, we would typically do it 3 months.
Perfect. And then in terms of that, we now have an antibiotic holiday. Who then gets an aspiration, or do you do ESR? So after you do it, and we're not going to include Thorsten here, unfortunately, he doesn't do a holiday, but people get blood work. If the blood work's normal, or do you get an aspiration as well? Who here is doing an aspiration prior to reimplantation? Okay, so Ed, you put up your hand pretty quickly. What's your criteria for a normal aspiration? Is it MSIS criteria? Is that where you're using 3,000 cells, 80%
Yeah,
neutrophils?
3,000 cells, DNA negative.
So you're saying it off for DNA. You're using your next-gen sequencing on that aspirate?
Absolutely.
Okay. And then, Mike, what do we typically utilize here at HSS, our institution?
Well, we do reaspirate, and we do follow MSIS criteria. With 3,000 white cells, positive cultures. Though I will say there is, we do the aspiration and the antibiotic holiday, a lot of it out of tradition and inertia. There is a body of evidence out there that shows that you can proceed without these if the patient is clinically well and the joint is functioning well and the incision is well healed. And I've seen that just in practice over the years. I've never accidentally uncovered an infection in an aspiration.
And then for our surgeons, you've done your 2-stage, you're finished, everything looked clean. Who is continuing to give the patient antibiotics after the reimplantation? You've put in some antibiotic cement. Who's going to treat with some antibiotics longer post-operatively after the reimplantation? Anybody? All right, so for Ashok and Arun, how long? Are we talking oral, intravenous? How long?
So we give oral intravenous during hospitalization. Post-operatively, we continue antibiotics for 6 months.
Okay. And then Arun, quickly?
2 weeks IV and then 3 months of oral.
And then Thorsten, finally.
6 weeks oral.
So thank you very much to our panel for these incredible responses, a huge amount of different topics that we covered. Thank you very much for your attention.